All right, if we can get started. Before I go on, any questions? Any of the material from yesterday? All right, well, we're going to go on and continue talking about the Rickettsia, and we'll start with these two groups of organisms, the Rickettsia and the Orientia. And we'll treat them together because basically their biology is similar, the diseases they cause are similar. In fact, at one time, Orientia was classified as in the genus Rickettsia. Okay, a little bit about their biology. Okay, these organisms infect endothelial cells in the small blood vessels, okay? Now, obviously, endothelial cells usually are not phagocytic, and they actually, binding of the bacterium to the cell induces a phagocytosis-like process, and so that they actually get taken up into the cell after binding. And these organisms now have this is the second way that intracellular organisms can live. Remember, they can inhibit phagolysosome fusion. This one takes a different route. What this one does is it elicits a phospholipase and lyses the phagosome so that it escapes into the cytoplasm of the cell. All right? And then in the cytoplasm of the cell, it will replicate. And then eventually will be released from the cell. And now, how it gets out, again, varies a little bit depending upon the organism that you're talking about. In the case of Rickettsia prowazekii, it actually lyses the cells and the Rickettsia, the progeny, are released. In the case of, this should be Orientia. Again, remember, this was just recently reclassified as Rickettsia. Orientia. So sometimes you'll see it referred to as Rickettsia tsutsugamushi, but actually it's Orientia tsutsugamushi. Now, this one actually buds out of the cell. All right? And in the case of Rickettsia rickettsii, it actually, what this one does, this organism associates with the actin filaments. And if you look at EMs of this organism growing in the cell, it actually has these actin tails that sort of help push the organism out through filopodia, and then they get pushed out of the end of the filopodia. All right. So these are this group of organisms, the Rickettsia, are grouped into different groups based on their antigenic properties. And so we'll talk about each of these major groups of organisms. First of all, there's the spotted fever group. All of the organisms in this group cause a similar type of disease. And they have a similar antigenic structure. And this is by no means a complete list. There's a huge list of these Rickettsia. Obviously, we're not going to be able to talk about all of them. We're only going to concentrate on two of them, those that I've underlined, the Rickettsia rickettsii and the Rickettsia cari, the causative agents of Rocky Mountain spotted fever and rickettsial pox. And primarily, these are found, the reason we're covering these, obviously, is they're found here in this country as well. Where some of these others are found in just very unique geographical locations. The second group of organisms is the typhus group. And again, we'll cover two of these organisms, the Rickettsia prowazekii. This is the causative agent of that disease, epidemic typhus. Again, not found so much in this country, but it can be. There's a sporadic form that we'll talk about. There's also a recurrent or recrudescent form of typhus, a typhus that comes back after decades. This one is found worldwide and can be found in this country. The sporadic form of this disease, rather than the epidemic, this is a sporadic outbreak. This we find in the United States and, in fact, the south central part of the United States. The other organism is Rickettsia typhi, the causative agent of murine. This is also called endemic typhus. And again, this one occurs worldwide. And the final group that we'll discuss are the scrub typhus group. And the organism there is this Orientia tsutsugamushi, and it causes scrub typhus. All right. So how do these organisms cause disease? There are no toxins that have ever been described for this. The immune system doesn't seem to play a role in pathogenesis. What contributes to pathogenesis is basically the destruction of these cells. These organisms destroy the cells that they infect. And remember, these are infecting now endothelial cells. So if you start destroying the endothelial cells, one of the consequences is going to be there's going to be a leakage of blood into the tissue. When that occurs in the skin, it results in a rash. So you're going to see a characteristic feature of these organisms is the development of characteristic rashes that you're going to be looking for. And that's going to help you in the diagnosis. Now, the rash isn't really the problem in these diseases. The problem is that the endothelial cells in all the organs are being destroyed throughout the circulatory system. And so there's a lot of collateral tissue and organ damage. And the complications from this disease come from the destruction of various tissues and organs because of the damage to the endothelium. Both humoral and cell-mediated immunity are important in recovery from these infections. Antibody, even though these are intracellular pathogens, if antibody coats these cells and opsonizes the cells, then if they're taken up as an opsonized particle, they will be destroyed by phagocytic cells very effectively. So they will not survive within the phagocytic cells and can be cleared. Cell-mediated immunity is also obviously very important. These are intracellular pathogens, so we're going to need cytotoxic T cells in order to get rid of the infected cells. All right, so let's look first at the spotted fever group. The first organism, Rickettsia rickettsii, the causative agent of Rocky Mountain spotted fever. And here's a fluorescent antibody staining. This is using fluorescent antibodies, so detecting the rickettsial antigens in the infected cells. And there's our vector, the tick. This is the most common rickettsial disease in the United States. This is what you're likely to see if you see a rickettsial disease, okay, Rocky Mountain spotted fever. There's about 400 to 700 cases annually on average. But you see every once in a while we get these spikes, like, for example, here in around the 1980s, there seemed to be a spike where there were a few more, and then it came back down. So, but overall, you're talking about 400 to 700 cases annually. And although the disease is called Rocky Mountain spotted fever, in fact, the area of the country where you see it is right here. Here's a map showing the number of cases on average per year. And you can see the hot spot is North Carolina. We're second. Virginia has quite a few. So it's the south central United States where this disease is found. The reason it was called Rocky Mountain spotted fever, the first patient where the disease was described happened to be somebody that was in the Rocky Mountains, and so they got the name. But in fact, this is the hot spot or the hotbed for this organism. It's most commonly seen in the April to September months. Why do you think that is? What? Because this is when we're out, right? And remember, the tick is the vector. This is when people are out in the woods and getting exposed to the vector. So this is when you are most likely to see this, not in the winter months. And of course, the vector, this hard or this exotid or hard tick. Now, the organism, actually, we get infected via the saliva of the tick. And what happens, but the organism actually does not live directly in the salivary glands of the tick. The organism is actually found in the gut. And what has to happen is the tick starts taking a blood meal, and that warm blood meal then causes the organism, the rickettsia, to then migrate from the gut to the salivary glands. And then it gets into the saliva of the tick, and then we get infected. So obviously that takes some time. So prolonged exposure to ticks is necessary in order to get transmission of this disease. Now, the reservoir for the disease is actually the tick itself, because there's transovarian passage. So the tick will pass it on to its offspring. But in addition, reservoirs are rodents in the wild. And typically, in nature, the cycle is usually tick to tick to tick and just passing it that way, or tick to rodent, and so on. And obviously, we become accidentally infected if we're exposed then to the tick, the infected tick. Now, here's some the statistics over the last several years. And you can see it looks like there's a little bit more than the 400 to 700 cases that are there on the average. So we may be in a little peak here. Here's the numbers for South Carolina over the last couple of years. Okay, so what does the disease look like? After an incubation period, again, which can vary depending upon the bolus of infection, but it'll be somewhere in the range of 2 to 12 days. There's an abrupt onset of fever, chills, headache, and myalgia, very nondescript type symptoms. And you'll see that through today, every organism that we're talking about today, pretty much, this is what it's going to start off as. Fever, chills, headache, and myalgia. But then a couple days later, the rash develops. And in the case of Rocky Mountain spotted fever, it's fortunate that actually most people that get infected develop the rash, because the rash is what you're going to use to help you diagnose this thing. And the rash is a very unique rash. It begins on the hands and the feet, and then extends towards the trunk. It goes up the extremities and then towards the trunk. The rash is a maculopapular rash, but later on it can actually become particularly and even hemorrhagic. But primarily it's maculopapular. The other feature of this rash is it doesn't spare the palms of the hands and the soles of the feet. A lot of rashes will spare the palms of the hands and the soles of the feet. This one does not. So what you're going to be looking for is this characteristic rash that may involve the palms and the soles of the feet that starts on the hands and feet, spreads towards the trunk. That's referred to as centripetal spread. All right, here's a picture of the rash. You can see it on the feet. And if you look up further up the leg, there appear to be fewer lesions, so this must be early in the disease. It's migrating up the extremities, and then we'll go to the trunk. Can't see the soles here very well. Okay, but again, the rash isn't the problem. The complications come from the fact that there's widespread vasculitis and the destruction of the vasculature. And so there are all sorts of other complications. There can be gastrointestinal problems. There can be respiratory problems, the seizures, coma, renal failure. So all the organs basically are being damaged because of the destruction of the endothelium. Obviously, these complications arise most likely when the rash doesn't appear. But again, fortunately in this rash, most patients develop the rash. But when it doesn't, the prognosis is not very good. Mortality rates can be as high as 20% in untreated cases. Okay, so how do you diagnose this disease? This disease has got to be diagnosed on clinical grounds. You've got to look for that rash, and you've got to treat. And obviously, take a good patient history, find out whether there's an exposure to a recent tick bite, all right? So this has got to be done on clinical grounds. You don't wait, you treat. The laboratory can help you ultimately confirm your diagnosis, but you've got to make it on clinical grounds. So what can the laboratory do for you? There is this fluorescent antibody test. We saw the picture of that. What you're going to do is you take a punch biopsy of the skin, send it off to the lab, and they'll treat it with the fluorescent antibodies and look to see if the organism is there. None of these tests are going to be done in the routine clinical laboratory. These are all going to have to be sent out to reference labs, so you're not going to get the results back right away. So that's one test. The labs are also now using PCR-based methods to detect these organisms. Now, I put this in here. I will not be holding you responsible for it. I don't want to ask any questions on this test. The test is no longer recommended. I'm just telling it to you for your own information if you ever hear this term so you have some idea what they're talking about. And that's the Weil-Felix test. What this test, this was a test that was done a long time ago. And basically what it is it takes advantage of the fact that many patients that are infected with Rickettsia rickettsii actually develop antibodies, but these antibodies cross-react with various species of Proteus, the organism Proteus. And so the Weil-Felix test was a test where you took the patient's serum and to determine whether or not it agglutinated Proteus. And if it did, that was an indirect indication that you might be dealing with a Rocky Mountain spotted fever. It's not recommended, this test anymore, and it's not used because, number one, it's not specific for rickettsia, obviously. If a patient had a Proteus infection, they're also going to develop antibodies against Proteus. And it's not very sensitive either. Not all the patients that that get infected with rickettsia actually develop these antibodies. I just included, as I said, just so that you've heard the term and you know what it is if you ever come across it. Serology, there are fluorescent antibody tests for looking for antibody, and there's also latex agglutination tests looking for antibodies to these organisms that the lab will do for you. But again, it's only for confirmatory purposes. You've got to make the diagnosis on clinical grounds. And the treatment is tetracycline and chloramphenicol. And these organisms respond quite well to treatment. And if you get treatment early enough, there won't be any of those complications that come up. There's no vaccine that has been developed for this organism. And prevention. One way, obviously, to prevent it is to prevent tick bite. So if you have patients that you know, that you're seeing, that you know are outdoors people, educate them. Try to tell them that you need to use protective clothing, insect repellents, anything to keep the ticks from biting. Or if they do bite, remove those ticks promptly, because it does take a while before the organism is actually transmitted via the saliva. So prompt removal of ticks will also prevent transmission. Obviously, there's no way we can control the reservoir in this case. The reservoir is in nature, the ticks and the rodents. Now, here's a case of a clinical case that appeared in I forgot where I got this thing from, but this is an actual case. A 6-year-old presents with a 1-day history of fever, headache, myalgia, and a macular rash on the arms, legs, palms, and soles. All right, so he's coming in with the classic signs of Rocky Mountain spotted fever. There's a history of a tick bite. He was bitten by a tick several days prior to that. They diagnose a viral illness, and they give him a cephalosporin. These aren't active against rickettsia. A few days later, the patient's is hospitalized, okay? Confusion, thrombocytopenia. This is also very commonly seen in this disease, thrombocytopenia. Goes into the next day, disseminated intravascular coagulation, again, very common in this disease. Now they start giving them tetracycline. That's the right antibiotic, but it's now several days later. The patient goes on to develop gas gangrene, has to have a limb amputated. The upper stomach and distal esophagus has got to be removed because of gangrene. And the patient dies about a few weeks later. When they took the serum samples from these dates and looked at them, they were all both positive for rickettsia rickettsii. So if you miss the diagnosis, the patient is in bad trouble. Well, in this case, most patients, and I think that's the number was up there, it was something like 90% of the patients actually develop the rash. So most everybody does. Those that don't develop the rash, the prognosis is actually poor. But in most cases, they're going to, in this disease, which is fortunate, right? Because that's what you're going to need to look for. Any other questions? Okay. All right, that's Rocky Mountain spotted fever. Again, that's the one that you're likely to see, particularly in this part of the country. Okay. The next disease, rickettsia acari, the causative agent is rickettsial pox. Now, this one occurs in this country, but it just occurs sporadically, and there's not a lot of cases for this. The vector here is the house mite, and the reservoir is the mite itself. Again, there is transovarian passage of the organism from mite to mite to mite, and so on. But in addition, the reservoir are mice. Okay, and again, we obviously become accidentally infected if we get bitten by a mite that has got the organism. The disease actually starts off, first of all, just as a little papule at the site of the bite. There may be scab formation on the thing, but you're not likely to see the patient at this point because it's just a little papule, and it goes away. But then the next phase comes in, which is several weeks later, with the sudden onset of fever, chills, headache, and myalgia, same symptoms, okay? And then you get this rash, unlike the rash of Rocky Mountain spotted fever, is a generalized rash. It doesn't start any particular place. It's a generalized rash over the body. And the rash is different as well. It's more vesicular, and it crusts over. It looks very much like the rash of chickenpox, which is why it's called rickettsial pox. Right? So it's a different appearing rash. The other one was more maculopapular. This is vesicular and with crust. And so this is generalized over the body. But this is really actually a mild disease. Patients recover. Fatalities are rare. It looks worse than it is because you have these pock marks all over the body. But they'll recover, and it's a very mild disease, actually. So it's diagnosed again. All these most of the diseases that we're going to talk about today are not going to be done in your routine clinical laboratory. They're going to be done by reference laboratories, and treatment is going to be the same. In virtually all of these cases, you're going to see the treatment is going to be tetracycline and chloramphenicol. And obviously, the way to try to prevent it is control the mouse population. All right, those are the two the spotted fever group organisms that we're going to talk about. Again, keep in mind that there are a lot of other spotted organisms in the spotted fever group. But we won't cover them, but you may hear lots of other rickettsia. The next group are the typhus group of organisms. And the first one we'll discuss is the Rickettsia prowazekii. This is the causative agent of that epidemic typhus. This is a serious disease in this group. This one also causes this recurrent form of the disease that comes back decades later is also referred to as Brill-Zinsser disease, after the two people that have studied this disease. And here's again the organism stained with the fluorescent antibody in the cell. And there's our vector, the body louse. Now this is the one, as we said earlier, is associated with wars and famines. But there are parts in the world, not obviously in the United States, but there are parts of the world where this is found. And the vector was that human body louse. Now this one gets transmitted in a different way. The bacteria is actually found in the feces of the body louse, not in the saliva. And what happens when the louse bites us, what is your tendency to do? You go like this, right? You're going to scratch this area. And what we actually do is we inoculate the feces into the bite wound, okay? And that's how we get infected. So it's found in the feces, not in the saliva. Okay? In this epidemic form of the disease, we're the reservoir for this disease. So the mode of transmission is human to body louse to human to body louse and so on. There's no transovarian passage. In fact, the body louse actually dies shortly after it gets infected. So it's human to louse transmission is the normal route in the epidemic form. Okay. Now, as I said, there is a sporadic form of this disease that's seen actually in this part of the country. Where the reservoir are flying squirrels, and the vector looks like it's the squirrel fleas, and so if we get bit by the fleas. But this is just occasionally you get infections. This is not the way the epidemic form is passed. The epidemic form is by human-to-human transmission. Human louse human transmission. All right, so what does the disease look like? Again, after some incubation time, typically about a week or so, depending upon the bolus of infection. What do we get? The sudden onset of fever, chills, headache, and myalgia. Same symptoms. And then a rash appears. But this rash is a little bit different. It is a maculopapular rash, which can develop into a petechial or hemorrhagic type. But primarily it's maculopapular. But this one spreads differently. This begins on the trunk and then spreads out towards the extremities. So we're talking about a centrifugal spread. So the rash is going to go in the opposite direction from Rocky Mountain spotted fever. And again, the rash isn't the problem. The problem is all the complications. There can be myocarditis, stupor, delirium. In fact, the word typhus comes from the Greek meaning smoke to indicate this lightheadedness and delirium that these patients have. So again, the problem is with the complications. And this is obviously not a complete list. They can be all the organs can be affected, just like you have in Rocky Mountain spotted fever, because of the widespread vasculitis. Okay, recovery can be very, very long. This is a real serious disease, and mortality rates can be really high. Now, I think you have to take into consideration when you're dealing with these high mortality rates, that in part, the high mortality rates, remember, this is occurring in times of war and famine, so people are not in the best of health to begin with. And then they get this disease, and that probably contributes to the thing. There haven't been very, very many otherwise normally healthy people that want to get infected with this to try out to see what the mortality rate is in a healthy population. But it's high in the population that gets it. All right. Now, this organism also causes this recurrent form or recrudescent typhus, epidemic typhus. And where you're going to see it are in people that were exposed in the Second World War. So decades afterwards, I mean, we're talking, 5, 6 decades after the end of the World War, these people are coming down with typhus, all right? And the disease is actually very similar to epidemic typhus, but except it's a lot milder, the disease. And a lot of times, and the rash will be rare. So basically, that's all you've got to go on is a patient that comes in with fever, headache, chills, and myalgia, very nondescript symptoms. But a good patient history, you find out that this patient had typhus back in World War II, and that can help you make your diagnosis. So obviously, in order to diagnose this, there has got to be a high index of suspicion. This one is a real toughie to try to diagnose. Fortunately, it's also a lot milder disease. These patients aren't going to die from the thing. So if you miss it, it's not going to be. The patient will survive at least. So how are these diagnosed? Again, the wheelphilics antibodies in this case also react with their antibodies against this organism also react with the Proteus, but it's not used anymore. It is possible to culture this thing, but most labs certainly are not going to do that. So you're left with serology as a way of trying to detect this. And there are latex agglutination tests. In the epidemic form, you'll see IgM antibodies. If this is the first exposure, IgM antibodies, then maybe later on IgG. In the Brill-Zinsser form of this disease, it's going to be an anamnestic response, so you're going to see IgG antibodies. Treatment is the same, tetracycline and chloramphenicol. And obviously, louse control measures will help prevent this disease. In fact, back in the Second World War, in the concentration camps, when the people that were sent to the gas chambers, they were told they were going in to be deloused to prevent this disease, basically. And that's what they were encouraged to go in to get to these gas chambers, basically to be deloused, to prevent typhus, because this was a major problem in the Second World War. There is a vaccine available, but we don't. I mean, this disease is not a problem in this country. Nobody's going to, get that vaccine. Only high-risk individuals or populations would ultimately get this disease vaccine, so we don't use it. Okay, the next organism is Rickettsia typhi, the causative agent of murine or endemic typhus. And this infection occurs worldwide. The vector is the rat flea, and again, just like with Prowazeki, the bacteria is in the feces, and we inoculate the feces into the bite mark. All right, the reservoir is the rat, and again, no transovarian transmission. So the normal cycle is going to be rat to flea to rat, and so on, and we become accidentally infected by the bite of the fleas. The disease, again, looks just like typhus. It starts with a sudden onset of fever, chills, headache, and myalgia. And then the rash develops, and it's the same type of rash beginning on the trunk and going out towards the extremities. So we get the same centrifugal spread of the rash. And it's a macular-papular rash. Everything is the same. It looks just like typhus, except this disease is much milder. It'll resolve itself even if untreated. Mortality rates aren't that high, but it looks just like typhus. Diagnosis is going to be the same by serology, and treatment is the same, tetracycline and chloramphenicol, and obviously control the rodent reservoir as a way to try to prevent the disease. All right, the last organisms in this group are the last group is a scrub typhus group, And the organism here is Orientia tsutsugamushi. This comes from the Japanese, where this disease is found. Tsutsuga is a small and dangerous, and mushi is creature. So this is a small and dangerous creature. And the reason it's called scrub typhus is because it's found in terrain with scrub vegetation, is where it's picked up. In this case, the vector is a chigger, which is the larval form of a mite. So we get chigger bites. And the reservoir is the chigger itself. So there is transovarian transmission in the chiggers and also in rats. And we become accidentally infected from the bite of the chigger. Again, same type of disease. It looks pretty similar. After an incubation time, sudden onset of fever, chills, headache, myalgia. Then you develop the maculopapular rash. Again, this one begins on the trunk and spreads out towards the extremities. So in all of these things that we've talked about today, Rocky Mountain spotted fever is the only one that goes the other way, and that's what you need to look for when in your diagnosis. All the other rashes are going to go in the other direction. And in the case of rickettsial pox, it's a generalized rash. Okay? Mortality can vary. Laboratory diagnosis is going to be by serology, and treatment is going to be the same, tetracycline and chloramphenicol, and obviously try to avoid exposure to chiggers. Will help control the disease. Okay, those are the rickettsia. The next organisms, we got a bunch of them to cover yet. The Ehrlichia and the Anaplasma. And again, this breakdown to Anaplasma is only in the last several years, so you're likely to see these things all referred to as Ehrlichia. In fact, the disease caused by both of them is called ehrlichiosis. Okay, so a little bit about their biology. These organisms infect leukocytes, and they're taken up by phagocytosis. And what they do is they inhibit phagolysosome fusion. So they're just like the chlamydia. They inhibit phagolysosome fusion. That's how they survive within the cell. So they bind to the leukocytes, they inhibit phagolysosome fusion, they replicate in the phagosome, and eventually lyse the cell. Now, just to make things interesting for medical students, rather than calling this an inclusion body, they came up with another word for you to remember, morula. All right, so this is called the morula, this inclusion body. It's nothing else but an inclusion body containing the organisms, okay? And then the cell lyses to release the bacteria. And here the organism, Ehrlichia chafiensis, Ehrlichia ewingi, and Anaplasma phagocytophilium. This one causes monocytic ehrlichiosis, and these two cause granulocytic ehrlichiosis. And here shows you the vectors. All the vectors are ticks. Reservoirs can be a little bit different, deers or small mammals here. And here's the geographic distributions. The one that we see here is chafiensis and ewingi. This one is found primarily in the Midwest and in Connecticut. All right, here's some statistics on the epidemiology over the last several years. About 600 cases a year. And here's our vector, the tick. Okay? And we'll start with the monocytic ehrlichiosis caused by E. chafiensis. Again, same type of symptoms. Sudden onset of fever, chills, headache, and myalgia. But in this case, most patients don't develop a rash. So that's all you have to go on, are those nondescript symptoms. There is, however, leukopenia, thrombocytopenia, and elevated transaminases. So what you're looking for is fever, chills, headache, and myalgia in a patient that is leukopenic, thrombocytopenic, and has elevated serum transaminases. Those are your clues, because in most cases you're not going to see any rashes forming. All right. Mortality rates are low. They're less than 5%. So these patients will recover even if untreated. Was there a question? Yeah.
Is the rash like the rash?
It's a maculopapular rash, but I'm not sure how it spreads. It doesn't go. I'm sure it's not from the hands and palms towards the trunk. I think it's either on the trunk or it goes the other way. Because Rocky Mountain spotted fever is the only one that goes centripetally. Okay. So how is it diagnosed? Microscopic observation can help, but it's really not a very good, it's not a very sensitive test. A lot of times this is picked up when a lab tech that's looking at a blood smear sees, I don't know if you can see it in here, the morula in the infected cell, okay? And this is monocytic, so we're looking at monocytes in the cells being infected. Not a very good way is for diagnosing this thing. If you catch it, if you see it, great, but you're not likely to see this or find that. It can be cultured, but again, the labs are not equipped to culture these things routinely. So serology is used, and there's also DNA probes are now being developed to help diagnose this disease. Treatment is tetracycline, all right? And obviously avoid ticks because that's where we get it from. Now, the other two organisms, Ehrlichia irvingi and Anaplasma phagocytophilium, cause granulocytic ehrlichiosis. And everything that we just said about the monocytic form applies to these organisms as well, except they're infecting granulocytes. So you have exactly the same type of story. The onset of fever, no rash, the leukopenia, thrombocytopenia, serum transaminases, all this is the same. Mortality is also low in these cases. You can use the microscope again. Now you're looking for the morula, of course, in the PMNs, now the PMNs, the granulocytes, rather than the monocytes. But everything else is the same. It's serology and basically DNA probes that are used to help to diagnose the thing. Now, treatment is going to be the same. There's no difference between these two diseases except the cell that's being infected. Okay? So everything is the same with those. All right. The next organism, Coxiella. Now this is an exceptional organism, and there's some things different about this organism. This is the organism is Coxiella burnetii, and it's the causative agent of Q fever. The Q comes from query. This was a fever of unknown origin, so it was questionable where this fever came from. We know now it comes from infection with this organism, Coxiella burnetii. And there's the organism stained with fluorescent antibodies. All right, so what is its biology? These infect macrophages. So Coxiella infects the macrophage. And this one takes the third form. Remember that Dr. Fox told you there's three ways the intracellular organisms can live. They can either inhibit phagosylysosome fusion, and we saw some examples of that. They can live in the cytoplasm, and we saw Rickettsia does that. And this is the third form. These guys actually survive in the phagolysosome. They are very hardy organisms, and they resist killing by the phagolysosome. So the phagosome forms, the lysosomes fuse with the phagosome to form the phagolysosome, and these organisms are quite happy to live in that environment. And they replicate in the phagolysosome, and then eventually lyse the cell and get out. All right? So we're dealing with a real hardy organism here. Now, the mode of transmission of this is by inhalation. Again, we're dealing with a very hardy organism. This organism is spore-like. And again, I'm not saying it's a spore because it obviously is different from the spores that Dr. Fox spoke to you about. But it's spore-like in that it resists these very harsh environmental conditions. And so what happens, it exists in the environment. If we disrupt and aerosolize or cause this stuff to get in the air, we inhale the particles, okay? So it's by airborne transmission. And then it first multiplies in the lungs, and then just starts disseminating to other organs. And where it particularly likes to disseminate is in the liver, and you get granulomas. So this infection is characterized by a pneumonia with a granulomatous hepatitis. Okay, so if you histologically, if you look, you'll see granulomas in the liver. Okay. Now, again, these are in severe cases. This disease is not everybody has these severe complications. This can be a rather mild pneumonia for many people. But if it does develop into a severe case, it'll be a pneumonia with granulomatous hepatitis. Now, there's a chronic form of this disease. And in the chronic form of the disease, immune complexes also play a role. And obviously, cellular immunity is going to be important for recovery. These are intracellular pathogens. Okay? Now, this organism undergoes phase variation in its LPS. Again, remember, phase variation is this ability to shift antigenic types as a way of evading the immune system. And this one undergoes a phase variation in its LPS. Remember, all these organisms that we're talking about are gram-negative organisms. In the acute form of the disease, the acute form is characterized by the organisms in just one phase, and that's the phase 2 of this organism. When this disease becomes chronic, that's when you get this phase shifting, and the organism evades the immune system. In this case, antibodies will develop against both the phase 1 and the phase 2 of the LPS of this organism. All right. So if it undergoes phase variation, that's going to lead to the chronic form of the disease. If it stays as a phase 2 antigen, then that'll be a more chronic disease. So again, this is a relatively stable organism. It infects a number of different animals, including sheep, goats, cattle, cats, and there are others as well. But it infects animals, basically. And there's particularly high titers of these organisms in the placenta of these animals. It's also found in the soil, because if the placenta is on the ground, the soil will get contaminated. These organisms are hardy, so they'll persist in the soil. They're also found in milk of the infected animals. And so where do you see these? And this is the exception here, of course. This is no arthropod vector. So you see these primarily in people that are around animals. And where do you find it? Ranchers, obviously. So again, this is an occupational disease. Ranchers get this a lot. Veterinarians that are treating these animals get it a lot. Abattoir workers, slaughterhouse workers. Okay, that's where you will tend to see this. So again, patient history is going to be important in narrowing in and including this as a possible in your differential diagnosis. It's an occupational disease. And again, here's some statistics. This is not a particularly common disease. This is some statistics over the last several years. These statistics are probably underestimates because this is not a notifiable disease in all the states, and in fewer than 40 states are actually reporting this disease, so we really don't have good stats on it. So what does the disease look like? All right, the acute form, again, this can be a mild form. It can be just a mild disease. It can be completely asymptomatic. But when there are symptoms, you'll get fever, chills, headache, and myalgia, same type of things. And then those that go on to develop pneumonia will again develop one of these mild atypical pneumonias. This is not going to be a very debilitating disease. But again, complications arise because these organisms particularly like to go to the liver. They can also go to the spleen, so you'll get hepatomegaly and splenomegaly. And if you look histologically, there'll be granulomas in the liver. So characteristically, pneumonia with a granulomatous hepatitis. The chronic form of this disease, and this is the serious form of the disease, actually presents as an endocarditis. So patients that have a damaged heart valve that have this phase shifting will develop an endocarditis. And prognosis is really poor. This is a serious illness. These patients don't do well when they get chronic Q fever. Fortunately, most people are going to just deal with the acute form. So how can you diagnose it? Is by serology. And again, the acute disease, you're going to be looking for antibodies to the phase 2 antigen. In the chronic form of the disease, you're going to be looking for antibodies to both phase 1 and phase 2 antigens. Treatment is tetracycline for the acute form. The chronic form is actually treated very aggressively with a lot of antibiotics because the prognosis is so poor. So this one is treated very aggressively, but tetracycline for the acute form. Again, vaccine there's one developed. We just don't use it here in this country. It's not a major problem, this disease. Again, here's a case study, an interesting case study with Coxiella. We have a woman that presents with a high fever, hepatomegaly, and elevated liver, so some signs of liver damage, and high fever. She was diagnosed with acute cholecystitis, and cholecystectomy is performed. Okay? Of course, that doesn't help her any, so nothing goes on. Her systems persist. Then they do a CT scan several weeks later, and she looks like she's got lung problems. So we've got lung problems with associated liver problems. Okay? Serum samples obtained at the time of the CT scan shows that she's got antibodies to phase 2 antigens for Coxiella burnetii, so she's got acute fever. All right? Her husband also gets sick. Same febrile type illness, just a couple days after her. And you look at his serum, and he's also got antibodies to phase 2, so he's got acute fever. Thing is, they're both treated with doxycycline, and they both recover. The problem is these people don't own goats or sheep or anything like that. So where did they get it from? What happened was they lived in where they had to drive down an unpaved road past a farm where a guy raised goats. And when they checked the goats in their neighbor, the goats were infected with Coxiella burnetii. So what obviously happened, the goats contaminated the soil. As they drove down this road, the spores, not the spores, but these organisms were aerosolized, not aerosolized, but they got into the air, they inhaled them, and they got sick. Okay? So again, even while you're going to be looking for, obviously, an occupational type disease, it does happen at times that people that don't have that occupation suddenly come down to it for reasons like this. Okay. And then obviously those goats, when they looked at them, tested positive. All right, the last organism we want to talk about is Bartonella. Now these organisms are actually sort of an exception to the rule in the reason that they're covered together with the Rickettsia and these other organisms that we've been talking about is because these things cause a disease. At least one of them causes a disease that is similar to typhus and epidemic typhus. And so it was just for historical reasons, these organisms were always, lumped together, and that's why we have them here. There really is no relationship between these and the Rickettsia at all. These aren't even necessarily intracellular pathogens, for example. So a little bit about their biology. These are gram-negative aerobic bacilli. They're difficult to culture, but they can be cultured. It's not that they're not culturable. A lot of these things affect animals. The animals may or may not get sick, but we get infected through vectors, and so it goes from an animal to some vector to us. And as I said, some of these things, some of them are intracellular pathogens. They infect erythrocytes, but a lot of them aren't even intracellular organisms. They just attach to the surface of cells. So they're really different than the other organisms that we've been talking about. And here's the group, the ones we'll talk about are Bartonella quintana. This one, again, has recently been reclassified. It used to be called Rashleimea quintana. And the other one we'll talk about is Bartonella Hensley. These are the diseases. This is the one why they're considered covered in this group. This disease, trench fever, looks a lot like typhus. Okay? And Hensley causes a cat scratch disease. So Quintana, the causative agent of trench fever. This is also called shin bone fever or 5-day fever. And again, this one, just like typhus, is associated with wars and famine. And the name comes from the trench. And when the soldiers would be in the trench, this is where it came from, the term trench fever. The vector here is the human body louse, just as it is in typhus. And just as we saw before, the organism is found in the feces and inoculated. The reservoir is our humans, okay? And so it's human to body louse to human in the times of war and famine. So that's the normal cycle for this organism. And the disease looks like typhus to some extent. There are some differences. You get the sudden onset of fever, chills, headache, and myalgia. But this one, the difference is that and I've never been able to find anywhere that can explain why this happens, but there's severe pain over the shin, and that's why it's called shin bone fever. The other thing is that these symptoms, this severe pain over the shin, seems to occur on a 5-day cycle. So every 5 days they have this severe pain again. And that's why it's called 5-day fever. A rash can develop, and when it does develop, it looks just like typhus. Again, this is why this organism was covered with the rickettsia. But it doesn't always develop. But you have this shin bone pain every 5 days. But it's a mild disease. It resolves by itself. It can be very debilitating because apparently the pain is very painful, and the soldiers, the troops that would get this, would be out of commission for while they were having the pain. Then every 5 days they're having troubles again. So it's a serious illness, but mortality is low. Diagnosis is by serology and reference laboratories. They also have PCR, but your clinical lab is not going to do this. You're not likely to see this infection anyway. Treatment is, there are lots of different antibiotics that can be used, and control of the body loss. The last one, Bartonella Hensley, the causative agent of cat scratch disease, this is one that you might see. Cat scratch disease, it's acquired, as the name implies, from the bite or the scratch of a cat. And there's also evidence that it might be transmitted by cat fleas. So the bite of the flea of a cat can transmit this disease as well. And this is really, actually it's a very mild, benign disease. That's all it is a chronic regional lymphadenopathy. So just inflamed lymph nodes is what you're going to see in this case, and a chronically inflamed lymph nodes. Diagnosis is going to be by serology, but there's really not a lot you can do for these patients because it doesn't respond particularly well to antibiotic therapy. And it is a very benign disease. It will go away eventually, but so there's no antimicrobial therapy. But you may see this one, but there's not a heck of a lot you can do about it. All right. Any questions on any of this material? I can't believe I actually made it. This is the first year I've made it.